Hello everyone, welcome back to Medical Coding Club. This is Chandrika. So in the last video, we have discussed practice question based on medical decision making. So in this video, I am going to discuss few more practice question based on time. Okay, so if you have not yet watched a previous video, please go back and check. And also if you have not yet subscribed to my channel, please do subscribe and share with your medical coding friends. So let's get started. So firstly, E&M time-based coding guideline. So we know that we follow two methods to take the E&M level. Okay, so in this video, as I said, I am focusing on E&M, office and outpatient visits only. Okay, so total time. How to conclude total time? There are few guidelines. Okay, so what are the things that in the documentation you have to look for to conclude the overall timing? Okay, it is very important. So total time can be calculated based on include all face-to-face and non-face-to-face time personally spent by provider on the date of visit. So it should be on the date of visit. Okay, it should not be carried forward to any other day. It should be on the date of encounter. The provider whatever the time he will spend on the particular patient, it will be calculated towards E&M total timing. And few exclusions are there. So it does not include time spent on activities normally performed by clinical staff or separately reported service. So if the physician is not performing any of the services, or the services can be reported separately. Okay, so with along with the E&M, if any other services provider is performing, where that other services can be reported separately. Okay, if you take example psychotherapy, in the psychotherapy, if provider is performing both evaluation and management and psychotherapy coding also based on time only, but you cannot you cannot combine both psychotherapy plus E&M timing together, and you cannot give E&M code. Okay, you have to build psychotherapy separately, how much, say for example, if you have spent 20 minutes for psychotherapy, so this psychotherapy should be built separately. Okay, there will be an add-on code for psychotherapy, we will build that. And for evaluation and management, provider has spent 30 minutes. Okay, so this 30, based on this 30 minute, you have to take time. You should not add psychotherapy timing, and you should not make 50 minutes together. You should not code like this. Okay, psychotherapy should be built separately and E&M should be built separately. So that is the meaning of separately reported services. That is an exclusion. Whatever the service we have a code to build separately, that kind of scenarios don't combine and don't take towards E&M time calculation. Okay, so in the scenarios you'll be able to understand. So we'll see the scenarios as well. So before going to scenarios, just see activities counted towards the total time of provider. So what are the activities that we can take time towards total E&M calculation? So here, before the visit, reviewing the patient records, preparing to see the patient, during the visit, performing a medically appropriate history examination, counseling and educating the patient, family, caregiver, ordering medication, test or a procedure, and referring or communicating with the other healthcare providers, and if not separately reported. This is also important. And documenting clinical information and the health record, independently interpreting results. So this is also if not separately reported. If someone is independently interpreting the result, then we will be generally billing for the other physician. Okay, so that we have to make sure whether we are billing for another physician or not. And communicating results to the patient, family or caregiver, and after visit, coordinating care for patient. So all of these services uh, can be calculated towards E&M total time calculation. Okay, so they can document like reviewing patient records 2 minutes, and preparing to see patient 2 minutes. Okay, so likewise they can categorize time according to the particular service. Okay, say for example, coordinating care, he might have spent 5 minutes, and to order medication test, he might have spent 10 minutes. So like this, you can calculate everything. All this point we can take towards total time. Okay, we can just sum all of this and we can take total time. And in CPC exam, they don't give like this. They will just generally, they will just give provider has spent 35 minutes with the patient. Directly, they will specify how much time provider has spent with the patient. So for your extra knowledge, you should know how this time will be categorized. Okay. And also, activities not counted towards total provider time. So these are the activities we should not consider towards total time. So the performance of the other services that are reported separately. So in the earlier slide, I have already given an example. If provider is performing any services which can be reported separately, so you cannot take those services timing. And travel. So if doctor is traveling, if he documents he traveled for 10 minutes, something like that, you cannot take that as your towards E&M calculation. And teaching, that is general and not limited to discussion, that is required for the management of the specific patient. So this is also we cannot credit towards total time. Next, prolonged time calculation. So first understand when to use prolonged time codes. Okay, so this prolonged time will be applicable only with the highest ENM levels. Okay, so if it is new patient 99205, and if it is established patient 99215. Okay, only with this level we will utilize prolonged service CPT codes. Okay, so we'll understand what is this and how to calculate. So additional time spent 15 minutes or beyond. So prolonged services we will use, so if we have any additional extra 15 minutes, we will code prolonged service code along with the highest ENM level. Okay, and billing rules, if less than 15 minutes, say for example you are getting 10 minutes additionally, so the 10 minutes will not be eligible to code prolonged service. Minimum you need 15 minutes. Okay, and also units are reported in 15 minutes increment. So for each 15 minutes we are supposed to give 1 unit. Okay, and again time spent on separately reported services is excluded. So as I give an example, whatever the service we are billing separately, those you cannot consider towards your E&M calculation. So we'll see the prolonged service code, so you will understand in a better way. So see here, outpatient and inpatient prolonged service. So as I said, we are only focusing on outpatient, but I'll try to give insight on inpatient prolonged service as well. So 99417 and 99418, these both codes are add-on codes. Okay, and we will be using these codes with the highest ENM level. So both are prolonged service code used to an account for an extended time spent on patient care that goes beyond the usual service time associated with a specific ENM codes carried out in the office or other outpatient ENM service or inpatient. So see the guidelines for 99417. So same thing will applicable for 99418 also, but 99418 will be inpatient code. So here 99417 prolonged service must occur in the office or other outpatient setting, because we are billing for outpatient setting, and this 99417 is only applicable for outpatient setting. So it can be applicable with ENM new patient, OP new patient, OP established patient, and also consultation and few more other outpatient services. 99417 must be used on the same day as a primary service. Okay, with the primary service you can utilize add-on code 99417 if you are meeting additional 15 minutes. And as I said, 99417 is an add-on code and must be coded in addition to the primary service code, and it is always like, as it is add-on code, it should be built with the level 5. Okay, and used 99417 used for 15 minutes for a prolonged time. do not use 99417 for any unit time less than 15 minutes. So if you are getting 14 minutes additionally, then also you should not consider one more unit. Okay, so if you are getting additional 29 minutes, in this case, you are supposed to give only one unit. Okay, for each 15 minutes, we will get one unit. For each, if you get 30 minutes, then you can give 2 units. If you get 29 minutes, you will be getting extra 14 minutes only, so that you don't have to consider one more extra unit. Okay. So again, 99417 can only be used by a physician or qualified healthcare physician. So this is for a provider, and for nurse it is not eligible. Okay, you can see the image here. 99417 is for outpatient service, and 99418 is for inpatient or observation nursing facility services. And if you are seeing CMS code, like these are the for CMS, that means for Medicare payer, we don't use 99417 in the outpatient setting. Instead, we do use G2212 only for Medicare payer. So this is the specific coding guideline, and for the CPC exam, you can focus on AMA coding. That is enough. Okay. So next we have split or shared visit. So split or shared visit means the visit shared between physician and non-physician provider within the same group. So when both physician and non-physician are a part of this patient service, we have to check, like the non-physician performed how much time, and the physician performed the service for how much time. Both we have to check, and we have to bill in a substantive way. Okay, so you can see this guideline. The split or shared visit is based on both time and MDM. Okay, so here time for both providers may be combined, and overlapping time is not included. If using MDM, the provider is responsible for the substantive portion of the visit, takes the credit. So in MDM, what will happen? Medical decision making. Here, though the non-physician may perform vitals and the physical examination, the provider will be purely responsible for the establishing diagnosis and the coordination of care. Okay, so that his part will be a more substantive, so that he will be getting credit. And again, if it comes to time, okay, time, if it comes to time, here we will check how much nurse practitioner has spent and how much physician has spent, and we will combine, and again we are going to bill for the person who has spent more time. Okay, so you can see the example here. Nurse practitioner spent 15 minutes and physician spent 20 minutes. So physician service is more, and you can just combine totally 15 minutes from NP, 20 minutes from physician. Totally you are getting 35 minutes. So for 35 minutes we will be billing an ENM. Okay, and the billing procedure, we have like a different guidelines. So that will be based on we will follow some rules, and based on that we will give the split or shared visits. So just be aware, should know what is an idea about split or shared service. So next MDM versus time. Here this is very important. Please be give attention and listen to this. So coders and providers are required to choose ENM visit level based on either medical decision making or total time spent on the date of visit. Okay, so we know that we are following two guidelines. One is MDM and one is total time. And what if in the same scenario, if you are getting complete documentation regarding medical decision making, as well provider also documented time. Okay, in this case, use whichever method allows the highest appropriate reimbursement. So in this case, you have to follow both the methods. Okay, you have to once check what is your level based on medical decision making, and what is the level you are getting based on time. Okay, so if you are getting based on time. If you are getting high level, then you have to go based on time. Okay, whatever the level will give you highest level, we have to follow that. Okay, but in CPC exam, how they will question? They will question clearly based on select ENM level based on time, based on MDM. So likewise they will question. So whatever they are questioning, accordingly you can select an appropriate ENM level. So if you are working, then it will be helpful for you. So both MDM and time is documented, means whichever is giving you the higher level, you have to follow that particular coding guideline. So although not every ENM services will have both time and MDM guidelines. Few services will have both MDM and time guidelines, but few services will purely depend on only MDM, and few services will depend on only time criteria. In those cases, we will left with only single coding guideline, so we have to follow that. So example, you can see here, critical care. In critical care, we don't have MDM concept. We have to go by time. We will see how much time critical care has been performed. Based on that, we will code critical care. Same way, if you take an example of emergency department, here in emergency department, we don't follow time-based coding guideline. Okay, we don't have time-based coding guideline. We only have MDM. So based on MDM coding, we have to follow ED codes. Okay, but as we are discussing office and outpatient setting, here we follow both the methods. For office and outpatient, we have MDM method also and time method also. So we have to be very careful and we have to choose wisely. So next scenario we will see based on MDM versus time. So see here, see the practice question. In the practice question, finally, if you see the last line, they are questioning on, based on documentation provided, what is the appropriate ENM code for this visit? Consider both time and MDM to determine the highest reimbursable level. So that means you have to check both MDM and time guideline in the same question, and whichever will give you the highest level, you have to follow that method. Okay, so let's see the question. A 60-year-old, a female established patient with a history chronic obstructive pulmonary disease, so COPD, present for follow-up visit. She reports worsening. Okay, so this is a chronic condition. Chronic condition is worsening. That means chronic illness with progression or exacerbation. Okay, so your P problem addressed is moderate. Okay, next, past week, despite of adhering a prescribed medication, including her inhaler, the provider performs following: review the patient recent chest x-ray and a pulmonary function test result which indicate the progression. He conducts a review patient medication regime and discuss the patient side effect, adjust the patient treatment plan, and he described the corticosteroids. Okay, so PDR, as we are checking level based on MDM, check MDM. P is moderate. And what is your data? In the data, if you check patient review the patient recent chest x-ray and pulmonary function test results. Okay, so he has reviewed the two records. That means you will be getting in the first review of medical records. So almost you will be getting your data as limited. Okay, and then finally he prescribed the RX. So the risk is prescribed medication, so moderate. So data, leave about data here, only concentrate on problem. Problem is moderate, risk is moderate. So your overall MDM will be moderate level. Okay, that means level 4 you will be getting. Level 4 you will be getting according to MDM coding guideline. Now check for the time. The provider spends 30 minutes on the encounter. Okay, 30 minutes on the encounter. So for 30-minute established patient, you will be getting level 3. Okay, you will be getting level 3, so that you have to go by higher level. Higher level you are getting based on MDM. So as you have the documentation supporting for level 4, you will go with the level 4. 99214 will be the correct answer. So this is how you have to, you have to distinguish between total time and MDM. So whichever will give you the highest reimbursement, go with that particular coding guideline. Okay, I hope you have understood. So now we will see questions purely based on time. Okay, so it is very easy. So as they are questioning based on time, just see the total time and take the ENM level. Okay, so a 50-year-old patient, which is like he's an established patient with the type 2 diabetes and hypertension presents for follow-up visit. Provider spends 25 minutes. Established patient 25 minutes. 99213. So if you see 99213, low MDM and 20 to 29 minutes, up to 29 minutes we can take level 3. So 99213 will be the correct answer. Okay, so as you know, you should be able to like the range you should know. So say for example 99212 is 10 minutes must be met or exceed. 10 to 19 minutes you can code 99212. Same way 20 to 29 minutes you can code 99213. And 99214, 30 to 39 minutes you can code 99214. And then 99215 is for 40 to 54 minutes. Okay, 40 to 54 minutes you can code 99215. And as I earlier slide I have already discussed 99417, it's an add-on code. And if you see, so if you get additional 15 minutes, okay, we can take 99417 along with the 99215. Okay, so we'll see the example for that also. So as of now, for this particular question, answer is 99213. Okay. So next question, a 34-year-old new patient present with an occasional headache and mild fatigue. The provider spends 30 minutes taking detailed history, performing physical exam and discussing potential causes. What is the appropriate NM code based on the time? So 30 minutes, new patient. So I have added the new patient codes here, you can check. So new patient codes 99202, 203, 204, 205 and prolonged care codes. And please be aware, whatever the time you see for new patient, that will not be same for established patient. Okay, established patient will have a lesser time for each level, but here for new patient generally it will have more time. Okay, so 30 minutes new patient means you will be getting 99203. So 99203 will be the correct answer. So next question, a 48-year-old new patient with a newly diagnosed autoimmune disease is evaluated. The provider spends 60 minutes reviewing history, discussing treatment and creating a management plan. Okay, 60 minutes. So for 60 minutes, we will be getting level 5. 99205, 60 to 74 minutes. You can take level 5. 99205 you can code it. So answer is D. And here you have to be careful. A 75-year-old established patient with advanced Parkinson's disease present for a follow-up. The provider spends 40 minutes on detailed evaluation and 30 additional minutes in counseling. Okay, so here 40 minutes for evaluation and additional 30 minutes for counseling. So it will give you around 30 plus 40, 70 minutes. Okay, 70 minutes established patient. So for 70 minutes established patient, if you check 99215 medically appropriate history or exam and MDM is high, time 40 to 54 minutes, we will consider 99215. Whereas if you are billing for a prolonged care code, you should consider from the least value. Okay, so from 40, additionally, how much time you are getting? So from 40 additionally, we will be getting 30 minutes extra. Okay, so for 40 plus additional 15 minutes, you will get 55 minutes. So you will code 99215 one time, 99417 unit 1. But we have additional 30 minutes. That means we have to give units 2. Okay, 99215 will carry 40 minutes. 99417 with the units 2 will give you 30 minutes. So totally this is how we have to code. So the answer should be answer B, 99215 and 99412 with the units 2. Okay, say for example, in this same scenario, if the provider, if he has spent 60 minutes or 65 minutes, okay, total time is 65 minutes, established patient. In this case, you are supposed to give only one additional unit. Okay, instead of 2 unit, you would have given only 1 because you are not getting additional 15 minutes after 1 unit. Okay, so for 55 minutes, you will get 1 unit and left out is only 10 minutes. So for only 10 additional minute, you cannot give one more unit. Okay, so as I already told you, for each 1 unit increment, you need additional 15 minutes. If you are not meeting extra 15 minutes, then you are not supposed to take one more extra unit. Okay, so for this particular question, the answer is B. Okay, why we are taken 99417 as an add-on code? Because we are dealing with the outpatient E&M setting. So next question here, a 50-year-old patient is seen for an evaluation, a complex chronic condition. The provider spends 78 minutes on evaluation and management and additionally 5 minutes performing concern and coordinating care. 78 plus 5 minutes, so you will be getting around 83 minutes. So options like all are new options are there, so patient is new only. So for 83 minutes, how we can bill? So if you see 99205 is for 60 minutes and 99417 we will code from 75 minutes. So if you get 16 plus 15 extra minutes, you will get 75. Okay, so in this case we have 83 minutes. Okay, so that means we have to code 99205 along with 99417 only one time, because you are meeting only additional 15 minute time increment one time. Okay, so left out is only how much? 8 minutes. So for this 8 minutes, you cannot code one more unit. So you have to only consider up to 75 minutes. So just give 99205 and 99417 into one time. So 99205 and 99417. Answer B will be correct. Okay, and remember 99417 or 99418 you cannot use with 99204. It should be used only with the highest ENM level we have. Okay, with level 5 only you have to use this prolonged service course. Okay. Okay, so okay guys, that's all for today. I have just tried to explain in a simple way. So please subscribe to my channel, and if you find it useful, please do share with your medical coding friends. Thank you for watching.